For my final project, I chose infant mortality in Louisiana. Louisiana has the second highest infant mortality rate at about 8.9 deaths per 1,000 births in the United States. High infant mortality rates are closely associated with low socioeconomic status, smoking, and single motherhood. Furthermore, infant mortality rates are significantly higher among non-Hispanic blacks at about 11 deaths per 1,000 births compared to their white counterparts at 5 deaths per 1,000 births. In regards to the social ecological model, at the individual level, rates of infant mortality are among non-Hispanic black children are higher than any other ethnic group and twice that of Caucasian children. In regards to education, infant mortality is lowest in the highest education group and increases in the lower education groups. Sufficient education can lead to higher family income and better health care. At the interpersonal level, marital status is a factor that may be closely related with infant mortality. For example, the risks of infant mortality among unmarried white women relative to married white women are highest among 25 to 29-year-olds. The degrees of social support, such as trust, networks, and connectedness, were strongly linked to infant mortality rates in non-Hispanic blacks. Social support can increase the diffusion of knowledge on healthy behaviors and increase the collective action leading to policies that provide health. At the organizational level, access to Medicare and Medicaid helps to ensure that women in Louisiana have better access to healthcare once they become pregnant. Women who are healthy and have access to healthcare prior to becoming pregnant are reputedly less likely to experience problems during their pregnancy. Difficulties in the implementation of Medicaid programs, combined with the enrollment of high-risk women and infants, limit the likelihood of positive outcomes. It has been suggested that Medicaid coverage is inadequate to compensate for the socioeconomic deprivation that recipients may have experienced. Therefore, Medicaid for infants may be at higher risk of dying of causes, but perhaps they are not at risk to the extent that they might have been without Medicaid insurance. At the community level, religious institutions often act as advocates for the well-being of families and children, which ultimately influenced infant mortality rates. For example, higher levels of community religious activity were linked to lower level of infant mortality rates, specifically among Catholic congregations, due to the focus on the creation of community-level care. On the opposite set of the spectrum, communities with a large proportion of fundamentalist churches, like Pentecostal and Evangelical, exhibit significantly higher infant mortality rates, which may be due to the elements of the church's faith in relation to quote-unquote faith healing, increasing a collective wariness toward medical interventions. Lastly, at the policy level, state programs such as the Louisiana Nurse Family Partnership has shown to improve birth outcomes. The program provides a nursing-based home visitation program for first-time mothers. Furthermore, these programs assist in the screening of expecting mothers for substance abuse, depression, and domestic violence. Although several policies are in place that assist vulnerable populations in Louisiana against infant mortality still remains at high levels in Louisiana compared to all other states. Therefore, increased awareness towards cultural backgrounds of regional residents is needed in order to address the basic mental health and social services needed of low-income women and families. Several proposed interventions are recommended in order to combat infant mortality in Louisiana. The first intervention is tobacco prevention. Women and their offspring often face additional health risks if women smoke cigarettes during pregnancy, as smoking by pregnant women increases the risk of low birth rate, prematurity, placental abruption, and other issues including sudden infant death syndrome, or SIDS. Including interventions that can be instituted in adolescence and prevent tobacco initiation before pregnancy or during pregnancy to increase cessation has been effective based on systematic reviews. In addition, interventions that increase the price of tobacco products reduce tobacco consumption in all levels of income. The next intervention that I would recommend is screening for depression. Postpartum depression is a real maternal health issue which affects moms, newborns, and families around the mother. Implementing a widespread depression screening by trained providers is often the first step in the intervention process by augmenting perinatal mental health. Furthermore, implementing initiatives to expand statewide provider education about depression screenings is key in bridging the gap between the identification and treatment of depression, especially in lower income women. The last proposed intervention is increased prenatal visits. Through this intervention, low-income women who suspect they may be pregnant will be able to schedule a visit to their healthcare provider for prenatal care. Prenatal visits to a healthcare provider include a physical exam, weight checks, and providing a urine sample. These visits also include discussions about mother's health, the infant health, and any questions about the pregnancy. In regards to proposed evaluations for tobacco use, assessing laboratory data for the decrease of nicotine in the system will ensure that the intervention is working. During this process, tobacco surveys will be utilized in order to collect data regarding habits, behaviors, and knowledge about tobacco use among pregnant women in Louisiana. In addition, collection of blood and urine for nicotine levels on a consistent basis will be necessary to evaluate and track nicotine levels. In regards for screening for depression, measuring the symptoms of depressions in mothers-to-be in Louisiana will be key to determining if this intervention is working properly. Developing a perinatal depression screening program will be needed as the foundation of collecting baseline data for depression. Furthermore, demographics will be measured to determine if pregnant, low-income, ethnically diverse women would be receptive to the perinatal depression program. Lastly, evaluating for increased prenatal visits would encompass measuring repeated pregnancies or pregnancy-related issues among women in Louisiana. Participants will be recruited from clinics throughout Louisiana, and baseline data will be measured in association with birth weight, planned and unplanned pregnancy at 1 year postpartum, employment and school attendance at 1 year postpartum, and other issues associated with pregnancy. In terms of potential challenges and barriers for tobacco prevention, local health officials, community members, and clinicians may have difficulty determining what interventions would be culturally acceptable and feasible. In addition, healthcare plans can promote smoking cessation by covering treatments. However, plans have several reasons for not providing these benefits, making it less appealing to quit among women in Louisiana. In terms of screening for depression, a culturally sensitive intervention will be needed to reduce culturally mediated psychological, social, and environmental barriers to care for depression are related issues in mothers-to-be in Louisiana. In addition, linking clinical and system strategies, such as supporting providers and patients to navigate community services, will reduce fragmented supportive services in public sector systems. Lastly, a key obstacle in increased prenatal visits is successfully implementing a prenatal health and treatment program, as well as getting information to women who are most in need and convincing them to follow this urgent medical advice. For example, some women who have already used drugs and alcohol while pregnant may be reluctant to receive help out of fear or shame. In terms of the logic model, and for the sake of time, I'm just going to give an example from each of the categories to illustrate the three interventions previously proposed. In terms of tobacco prevention, resources and inputs would include cooperations with clinicians, local health officials, and community members to determine feasibility. Actions would include birth preparedness. Products would include number of patient surveys administered and questions answered. Outcomes and objectives would be increased knowledge and preparedness for smoking and cessation. And lastly, impacts would include decreasing smoking rates in women in Louisiana. In terms of screening for depression, resources and inputs would include collaboration with local, public, and private partners in Louisiana, Actions would include training and professional development of home visitors. The product would be increased number of families and children served by high-quality home visiting services. Outcomes and objectives would include reduction in maternal mental health issues, and impacts would generally be enhanced maternal well-being and social competence. Lastly, increased prenatal visit resources and inputs would include safety net providers, including hospitals, clinics, and substance abuse treatment providers. Actions would include patient education and web training. Products would include culturally appropriate materials. Outcomes and objectives would be improvements in access to care. And lastly, the impact would be less alcohol and tobacco exposure during pregnancy. Overall, in regards to further identifying and defining the problem, health educators are responsible for the continue of reviewing studies and epidemiological data in order to further understand current trends and issues related to infant mortality, specifically to the cultural background of regional residents, since non-Hispanic Black females have increased rate of infant mortality. As the non-Hispanic Black population continues to increase in Louisiana, it has become increasingly essential that health educators increase awareness about infant mortality, creating a healthier future for the population of Louisiana.